In this video, we will talk about SGLT2 inhibitors, a class of drugs used to control hyperglycemia used in the treatment of type 2 DM by targeting the kidney's rolling glucose homeostasis. So, in healthy individuals, the normal blood glucose level is maintained because the kidney completely reabsorbs glucose from the filtrate back into the blood. So, as a result, no glucose will be excreted in the urine. Now, let's understand how glucose reabsorption happens in the kidney. So it mainly takes place in the proximal convoluted tubule or PCT of the nephrons, specifically in the S1, S2, and S3 segments. And this process actually requires special transporters called sodium glucose cotransporter or SGLTs, primarily SGLT2 and SGLT1. Here is how it works. The glucose enters the tubular cells from the lumen through the SGLT transporters and then move into the bloodstream through GLUT2 transporters located on the basolateral surface of the cells. The PCT therefore act as a barrier with two sides, the luminal surface which faces the glomerular filtrate and the basolateral surface which faces the blood supply. And but how this SGLT works? SGLT works by using the electrochemical gradient of the sodium, and that's the key. This gradient acts as the driving force to pull glucose molecules against the concentration gradient from the tubular lumen into the cell. In simpler terms, we can say that the sodium moves down its concentration gradient. That means from high to low concentration, and the glucose is also getting carried along with it, even though the glucose moves against its concentration gradient. So this process directly does not use ATP directly, and so it is called secondary active transport because it indirectly depends on ATP used elsewhere to maintain that sodium gradient. But how is the sodium gradient maintained? On the basolateral membrane, an enzyme called sodium potassium ATPase pump is there, and this pump actively transport free sodium out of the tubular cells and to potassium into the cell. But this pumping requires ATP, and it keeps intracellular sodium levels low because sodium is continuously pumped out, and more sodium from the filtrate wants to flow into the cell by the sodium glucose cotransporter, and it brings glucose along with it, and that is the foundation of the sodium glucose cotransporter mechanism. So once glucose enters the tubular cell by the sodium glucose cotransporter, it exits on the basolateral side through the GLUT2 transporters by facilitated diffusion. Then it diffuses into the blood, completing the reabsorption. Sodium, meanwhile, is pumped back out into circulation by the sodium potassium ATPase, keeping the cycle going. Next, we have a concept called RTG or renal glucose threshold. This is actually the plasma glucose concentration above which the SGLT transporters become saturated, causing the glucose to spill into the urine. In a healthy person, this value is roughly 180 milligram per deciliter. But here is an interesting paradox. In type 2 DM, the renal threshold will actually increases, sometimes up to 200 to 240 milligram per deciliter or even higher. That means the kidney's reabsorption capacity becomes stronger in a person with type 2 DM which is a maladaptive response, and it actually worsens the hypoglycemia by conserving more glucose instead of excreting it. This is where SGLT2 inhibitors come into play. They lower the renal glucose threshold, allowing excess glucose to be excreted in the urine by blocking this transporter, SGLT transporter, and thereby it lowers the blood glucose levels. These SGLT2 inhibitors have several advantages. First of all, it does not cause hypoglycemia because these SGLT2 inhibitors don't stimulate the insulin release, or it is not interfering with insulin sensitivity directly. So they simply promote the glucose excretion or glucosuria by blocking the glucose reabsorption in the proximal convoluted tubule. So this means their effect depends on the plasma glucose level, and if blood glucose level is normal or low, less glucose is filtered and excreted. So it does not cause hypoglycemia. And the second thing is it has a modest weight loss effect because each gram of glucose lost in urine equals to about 4 kilocalorie of energy lost. So the patient can excrete 50 to 80 grams of glucose per day depending on plasma glucose levels. That's roughly 200 to 300 kilocalorie per day of calorie deficit. So actually, on a long term, the SGLT2 inhibitors can cause slight weight loss. And the third thing is it reduces the blood pressure, or it can maintain the blood pressure when it is high. Because when glucose is excreted, sodium reabsorption also decreases. and because the glucose and sodium are co-transported by SGLT. So this result in the loss of sodium through urine and as well as the osmotic diuresis, that means the loss of water. So this mild volume reduction can lead to a decrease in plasma volume and arterial stiffness. So overall, the it can cause a reduction in systolic and diastolic blood pressure, typically around 3 to 5 mmHg, without triggering reflex tachycardia. And the side effects to remember with this drugs are uh, because more glucose remains in the urinary tract, it can provide a nutrient-rich medium for microbes. So hence there is an increased risk of urogenital tract infections, especially candida, candidiasis, and UTIs. So good hydration and hygiene can lower this risk. And this is about the SGLT2 inhibitors.